Hi, I'm Dr. Mindy Ross. I'm a pediatric pulmonologist at UCLA Mattel Children's Hospital. Thanks for joining me. The topic of today's webinar is the evaluation of chronic cough in children. If you have any questions, you can tweet them now or comment on the Facebook live stream. And the objectives of today's talk are to review your questions about what is chronic cough, what can cause it, and how is it evaluated by a pediatric pulmonologist, including what tests might be ordered. As for treatment of the chronic cough, I have a dedicated webinar for that on June 1st, so please tune in for that for more information. As for this talk, we're going to start off on why do we cough? So how does the cough help us? It helps us in many ways. One is that it protects our airway from irritants or dust particles. Also, it can clear out mucus that we make on a daily basis and the extra mucus we have when we're sick. And cough actually can be a good thing in that it can let us know it's a warning of the first sign of a disease. And in the next couple of slides, I'm going to talk about how we actually make a cough. So there are lots of steps to this, and the first one is called the irritant phase. And our body is triggered to make a cough because as part of our nervous system, we have many cough receptors. And this picture demonstrates that here. The dots are all the cough receptors which are strategically located. And their job, once they sense an irritant, is to send a signal up to the brain, to send a signal back to our body to actually make that cough. And the cough itself is a coordinated process. At first, there's a few steps to this too. The first one is the inhalation phase. This is where we take a deep breath. The second step is the compression phase, which is where we close our upper airway called the glottis, and then we can build up pressure down here in the chest. And the last phase is the expulsion phase over here, where the airway opens up and the air is forcefully pushed out by the muscles in our body. And I have a video of this just to kind of compare how fast the air is coming out of the airway compared to some common things we're all familiar with, such as a tennis ball. And the speed of that is about 50 miles per hour. And a baseball, up next, is about 85 miles per hour. And the speed of the cough, if you can believe it, can be about 100 miles per hour. So it's very important that we have this fast speed of air so it can generate the shearing forces to remove that mucus and dust particles and any irritants, get them out of the airway. And so next up is, how do we classify cough? How do we decide what's acute and chronic? And so the classifications are actually based on time. For an acute cough, it's a cough that lasts 4 weeks or less. And a chronic cough is when the cough is lasting more than 4 weeks. And so for acute coughs, they're usually caused by viral illness, the common cold. And the cough and cold symptoms usually last 7 to 14 days. And most of the cases, up to 90% of the time, the cough will go away on its own. And there are cases where a viral illness can cause a cough that lasts more than 4 weeks. But in the pediatric community, we use this 4-week cutoff because we really want to avoid missing any more serious underlying diagnoses that we want to identify right away and treat as soon as we can. And some examples of these are if there might be a foreign body in the airway. And this could be anything from a piece of plastic, a toy, or food. We want to make sure we don't miss any lung damage that may have happened as a consequence of an infection. And there's also genetic disorder or conditions that we want to make sure that we identify as soon as possible. One of these is cystic fibrosis, where the body makes thick and sticky mucus, so it's more hard to clear and can cause cough and lung damage over time. So when the cough becomes chronic, and if it affects daily functioning or is associated with other symptoms, then that is when we start to look for other causes of the cough besides a viral illness. And in speaking of cough causes, there are a lot of them. Some may be more likely based on your child's age. And I've listed some more common causes and less common causes over here. And unfortunately, there's not enough time in this webinar to talk about every one individually. Each of them could be its own webinar, and we actually have a couple of them on our website already as webinars, which is asthma and cystic fibrosis. So if you'd like to learn more, please visit our website. But the point of this is that there are many causes of chronic cough. This doesn't list all of them. And sometimes children can have more than one of these causing the cough. And there's a lot to think about going into this. So it can be helpful to have a pediatric pulmonologist involved in your child's care of a chronic cough, because we're trained to recognize, identify a lot of these causes and more. And so if your child does come into the pulmonary clinic for workup of a chronic cough, we'll walk through the steps what we do, and that will be the last part of this talk. We go over what we're looking for in the history to find clues of what might be causing the cough, what we look for on the physical exam, and then based on those things, that will help us find diagnosis or decide what testing to order. And so first up on the history, there are a lot of important parts of the history, but one is the timing of the cough. So that can point us in different directions. So if the cough happens shortly after birth, that's something different most likely than if somebody choked on a piece of food, or if the cough started after an illness, or if the cough started after they traveled to an area that had high rates of tuberculosis. And also on the history, the other symptoms that go along with the cough can be telling. So I've listed some examples here. We'll go through them. One would be if you tell us there's nasal congestion, congested nose, that can lead us in the direction of what's called the upper airway cough syndrome, formerly known as postnasal drip. And the causes of this can be allergies, secondhand smoke exposure, sinus infection, and even the tissue higher up in the airway, called the adenoids, can be larger than desired, and it can cause upper airway blockage. And if there's been wheeze with illness in the past or shortness of breath with activity, we may think of asthma. If you report heartburn for your child, that makes us think of gastroesophageal reflux, shortened as GERD. And this is when food comes up from the stomach and goes towards the airway and can cause cough. And actually, small bits of food or liquid sometimes can get into the lungs. And that is called microaspiration. And that can cause cough and sometimes long-term lung damage. So we're always on the lookout for that. The other thing is choking on food. If your child chokes or coughs when they drink liquids or foods, that makes us think of an issue with swallowing coordination called dysphagia, or some anatomical issues there. And in that we're worried for that microaspiration again. Also, if there is poor growth associated with the chronic cough, then that can make us think of cystic fibrosis. And finally, if there are more infections than expected for your child, that can make us think of, well, maybe there's an issue with the immune system we should look for. And so the physical exam, what we're looking for, or listening for, when we listen to the lungs with our stethoscope, or the sounds that we hear, and can point us in different directions. So an example is if we listen to the lungs and hear noise when the child's breathing out, wheezing, all throughout the lungs on both sides, and there's maybe tightness, that makes us think of asthma. But if we listened with the stethoscope and we hear the wheezing just in one area only, then that makes us think of maybe a foreign body, a foreign object is stuck in there in the lungs. And we also listen for a sound called crackling. It sounds like, and you can hear this crinkling tissue paper. And that can mean a lot of different things, but possibly infection or lung damage or extra fluid in the lungs. Also, if there's swelling, we look in the nose and some pale color, we think of allergies. If there's pain in the upper abdominal region, called here in the epigastric area, then that makes us think of heartburn, which is can be a sign of gastroesophageal reflux again. And then we also look even at the hands because there can be some clues there. We're looking for something called clubbing. As this picture, you can see if over time the shape of the nail bed changes and the shape of the fingertips changes, that makes us think that there could be some more chronic lung issue that can cause low levels of oxygen in the body over time. And also on the physical exam, what the cough sounds like can be important. It's not always perfectly predictive, but it sometimes can point us in the right direction. And sometimes your child might not actually cough during the visit, and that's okay. A good description from you is great. Also, if you can bring in a short video clip of the cough, that can be helpful. And so the sounds we ask about, or you might tell us about, is the cough wet? And that might mean infection, postnasal drip, airway damage. Is the cough dry? That can sometimes suggest asthma or airway irritants triggering the cough. And also, is this cough a very short, called staccato sound that comes in fits or spells, and the child has trouble catching their breath during it, or makes a noise when they breathe in, and half the time this might happen, and it's called a whoop. So this could be a sign of whooping cough caused by the Bordetella pertussis bacteria. And I have a little sound clip of that. You can hear. And you hear that little whoop noise when they breathe in, and that's a younger child. Again, not all children make that inspiratory, that noise when they breathe in. And then other types of cough, one sound you can hear is if it's makes a honking or brassy sound. Sometimes in acute infections or viral illness, you may have heard this with upper airway swelling, called croup, that sounds like a barking seal. But if that noise happens and it's a chronic cough, we think of other things. Sometimes the airways can be a little floppy or collapsible and make a brassy sound when the cough happens. The other thing that we look for is in older children and adolescents is called a habit cough. It's when it starts, there's a cough, but it becomes very loud and brassy and harsh, and it's disturbing often to people around the child. Luckily, it doesn't hurt the child or bother them. And one sign of this is that when the child goes to sleep, the cough totally goes away or completely goes away. And I have a clip of what that sounds like. So you get the idea of this harsh sound to it. And so that's everything we're looking for and more. There's more that we look for too. And then next, so based on that history and physical exam, that points us in certain directions, but usually after 4 weeks of cough, and if the cough's chronic, we're going to order a chest x-ray, because there can be a lot of clues from this, and even if it's normal, that's helpful to rule out certain things. And we're looking for things like we've mentioned the foreign body. There's an object in the airway that's causing the cough. Now, if the object's metal, we can see it pretty easily, but if it's not, like in the case in this picture, it's a popcorn kernel, and so we can't see that very well. But the x-ray can still give us signs that there is something stuck in the airway, because what happens is when the object is in the airway, it blocks the airflow. So you can see this black area is all the air trapped here on the right side. This is a diaphragm of our muscle under the lungs, and it pushes it down. And then you can compare, you can see the difference of the two sides, so you know something is going on this side. And we look at the lung markings. We see if there's more markings than we would expect, or signs of lung damage. And again, the diaphragms, if they're flat, it can show air trapping. And if it's on both sides and there's been wheezing, we think possibly asthma. And unfortunately, even in children, we do have to be on the lookout for tumors in or around the airway that can be causing the cough. And so also in the pulmonary clinic, very common tests that we do is pulmonary function testing, spirometry. So if your child's old enough, around 5 or 6 years old, they can try this test. And it looks like, the picture's a picture of it, looks like this. Your child will blow into this machine and it will measure the amount of air in the lungs and how much air they can blow out quickly. And we also usually give a medication called albuterol to help relax and open the airways. And if the numbers improve a lot with the albuterol, that can point us in the direction of this may be asthma. Another test we have is called exhaled nitric oxide, and this can be a sign of allergic inflammation that we look for. And these tests are very useful because each time your child comes in, we measure them, so we get this nice trend over time, and we can see if the situation's getting better or worse, if we need to make adjustments on medications, and can guide us of starting or even stopping, hopefully, medication. And so other tests that might be ordered, not always, but again, depending on that history and physical, are skin or blood tests to look for allergies. We may order a swallow study to look to see how the coordination and if there is food going towards the airway. And if you're referred to the gastrointestinal specialist, they may order certain tests to look for gastroesophageal reflux. Now, the tricky part about these two diagnoses of the reflux or dysphagia is that sometimes they can be happening and people don't realize it. So the only way to diagnose it, and it's called silent aspiration. And so the only way to diagnose this is by actually doing some of these tests. And another screening test we might order to rule out cystic fibrosis is a sweat test, where actually there's a medication that we put on your child's arm that can stimulate the sweat glands, and we collect the sweat and send it to the lab to look at the level of salt in it. And then if this cough is still continuing over time, and we've done all those other investigations and nothing has shown up positive, then we may recommend what's called a bronchoscopy, where this is where, well, your child is asleep for it with anesthesia. And this is where we actually look into the airways with a special camera to look at the anatomy, examine to see if we see any foreign bodies, and we can also do washings of the lungs and collect samples to send to the lab to help us with diagnosis. Another test we may do is a chest CT, and depending on the age of your child, they may or may not need anesthesia. And this would be done if we need to follow up on any findings of the chest x-ray, to look at anatomy, and sometimes to diagnose more rare lung disease. And at any time, actually, we may recommend these tests. Even after the first visit, it really depends on that history and physical or any red flag signs that you tell us where we may need to do these tests sooner than later. And so, the summary. Chronic cough has many possible causes. We recommend close monitoring by a physician until the cough goes away or a diagnosis is made. And we always strongly consider consultation with a pediatric pulmonologist to help get to the bottom of the chronic cough, to solve it. And, and why is it a benefit to visit the pulmonologist? Well, because in our clinics, when we do the lung function testing, it's performed by respiratory therapists who are special training, certification, and experience on performing these tests with children. And the doctors have many years of extra training in lung disease of infants, children, and adolescents. And we have detailed intake questionnaires and formalized questionnaires that we provide families. And just in general, it's a multidisciplinary group, and we have nurses, physicians, respiratory therapists, sometimes even social worker and dietitian to collaborate and educate families to give the best education on pulmonary disease. And so in our clinic here, all of us are trained to diagnose, manage, treat chronic cough in children. So if you're interested, please visit our website. You can also check out the other webinars. And if you have any questions, please go ahead and tweet them now. And I'll take your questions. Thanks. Okay, I sometimes hear my child cough, but what's normal? That's a good point, because we're always making mucus. It's one of our body's defense to protect our airway, and so we have to clear that mucus. So there is a normal amount of cough that people do. They've tried to measure it, and an estimate is maybe in kids 10, on average, 10 or so coughs a day can be normal. And you can think of this because when you're sitting in like a movie theater or a lecture, you always hear people clearing their throat or coughing, and it's just a natural process. But again, when it becomes more than their usual baseline of some certain number of coughs a day, or if it becomes worse or it lasts for a longer period of time, then that's when you should check with your doctor. And always never hesitate to ask your doctor what's normal for a cough either. And this goes along those lines too. When should I bring my child into the doctor for a cough? And the answer is, I have to say that depends, because if everything looks like a normal cold, runny nose and a little cough, and they're acting their usual selves, they're eating, they're drinking, they don't have trouble breathing, they haven't had fevers for a long period of time, or fevers that aren't controlled with medication, if you choose to give that, or if there's no blood and coming out. I'm sure you would talk to your doctor if you saw blood. But if they're acting their usual selves, you can watch and wait, and always, for guidance, call your pediatrician just to double check on that. But if you see any other of the signs I just mentioned going along with the cough, then you should get it checked out. You know, any new or worse symptoms, rash, anything like that, and bring them in. And then, of course, if it's lasting more than 4 weeks, you can always come to the pediatric pulmonologist for that. What if I don't bring my child to the doctor for their cough? What's the worst that can happen? Yeah, exactly. We all hope that the cough will go away, and as you saw, most of the time it goes away. So that's great. But then we are always concerned about those less common causes of cough, and so we don't want to miss that. So if there's anything like cystic fibrosis, something stuck in the airway that we mentioned, we always want to start treatment as soon as possible, because we want to prevent any long-term complications or lung damage down the road. Yeah, does the color of my phlegm matter? And that's a tough one too, because we don't always go by the color of the phlegm, but sometimes it can mean certain things. Clear phlegm could be allergies, and when you see a coloration, the yellow or green or just different, that can be white cells in the phlegm. They fight infection, but we can't usually tell by color if it's virus or bacteria. But it may mean that you have an infection of some sort, but we don't hang our hat on the phlegm color always. If there's blood, or if it's brown, if red, I should say, if it's red or brown, then we are concerned that there may be blood in there, and you definitely want to tell your doctor about that. So yeah, it doesn't hurt to add in the color of the phlegm, but it doesn't mean that we can diagnose 100% off of it. And one more. My child recently started daycare, and Now they always seem sick. Is this normal? Yes, yes, yes. We see this a lot. It's because it's the first year or two that kids go to daycare, they do seem sick all the time. And daycare is what we call the germ fest. It's everywhere. And yes, they will pick up some colds, but what's normal? And that's a tough one because we're always trying to sort that out, because they say what can be normal is 10 colds a year. And so if you think about it, that is almost being sick every month. And it seems like this never-ending symptoms. But then we're always looking for those other signs that I mentioned here: poor growth, lingering for longer than we would expect, and other signs to say, hey, maybe this is a little outside the usual of what we're expecting. And we just, based on other signs and symptoms and other history, we will decide if we need to do more investigation. And I think that's it. Yep. I think that's it. And thank you for joining me. And don't forget to tune in on June 1st for the treatment of cough webinar, and then check out our website for our other webinars on pulmonary disease. Thank you so much.